Hello, I'm Enrique Cerna, and welcome to MOHI, the Museum of History and Industry here on Seattle's Lake Union. It's been nearly 2 years since we began these community conversations, focusing on some of the critical issues in our region. Our first conversation back in June of 2016 focused on the heroin and opiate crisis here in King County, a crisis that has spread across the country. It's now a national epidemic. What's happening here in King County? Are we getting a handle on this crisis? What are we doing? And what are the challenges and the controversies? We're going to be taking a look at that tonight and much more in our conversation.
It's a public health epidemic, and it is at crisis levels.
We still have people who are dying every day.
Somebody who overdosed in their car on I-5.
Heroin or an opiate overdose kills someone in King County every 1.5 days, and the number is rising, not just for those on the street, but across all socioeconomic backgrounds.
I can speak personally that my brother died of a drug overdose 12 years ago, and he was a college graduate. He had a good paying, excellent job at a bank. He was doing well for himself, and nobody knew there was an issue until one day we got a phone call from the hospital that he had died.
In 2016, the Heroin Opiate Addiction Task Force was formed to find solutions. Its first recommendation: prevention.
All right, we have a very good panel with us tonight to talk about this issue. Joining us is Brad Finegood. He is the co-chair of the task force here in King County. He's also the Chief Health Integration Strategist for King County's Department of Community and Human Services, Behavioral Health, and Recovery Division. Thea Oliphant-Wells is a social worker for Public Health, Seattle-King County. Also with us is Dr. Caleb Banta-Green. He's a senior research scientist at the University of Washington Alcohol and Drug Abuse Institute. And also with us this evening from the Seattle City Council, District 4 is Rob Johnson. Please give them a warm welcome, please. Thank you very much. 2 years ago, we covered this issue. Both Thea and Caleb were here. Let's take a look at what's happened in that 2-year time, Caleb. Have we made progress? Because I think if you look at some of the numbers, you may not think we have.
Yeah, we've really changed how we're doing things, and I'm pretty excited about it. We certainly still see plenty of problems out there, but I think we're beginning to realize that instead of blaming people for failing treatment, that treatment's been failing people for too long, and we've really done something about that. We've started new services in the last 1.5 years in Seattle, where there's the opportunity for people who want to stop using drugs and opiates. 80% of people who are injecting opiates do want to stop. And so we're now offering services where people can get started on treatment medications that same day. And those services we've been building are serving over 80% homeless folks. So that's one of the biggest things that we've been doing, and it's something we're working to figure out how to expand. And we're actually working to expand it across Washington State as well. It's a very exciting model of care, and I think it's the most impactful thing we can do from a public health perspective. We worry about overdose, rightfully. Those treatment medications cut your chance of dying from an overdose by 50 to 80%. So they prevent overdose deaths and they support recovery long term. And we really want people to understand that. We want to not just be building more services, we want to be building the right services because we know people want to be accessing them.
Thea, you're in the front line of all of this, and you've also been there as someone that has had a problem in the past.
That's right.
How are you doing, by the way?
I'm well, thank you. Yeah.
Is it still a challenge?
It is, yeah. I mean, I think in the 2 years since I was last here, we've lost a lot of folks. A lot of my clients and friends have passed, but I've also gotten to see a lot of really amazing recovery stories in that time too. I've seen people who could not access treatment, no matter how hard they tried, really have an opportunity to recover in a way that they didn't have before.
You are on the task force as well, Caleb, and also Brad. How do you see the past 2 years since we last talked?
Wow, I
think we've come a long way. We certainly have a long way to go. We have designed some really innovative interventions and changed the way that we look at treatment, changing the way that people see the medications that are used to treat opiate use disorder. We're fighting stigma every day. Part of the stigma that we have to fight is toward folks who have opiate use disorder or other substance use disorders, and part of the stigma that we're dealing with is against the interventions, and some of those being medication-assisted treatment. I think we have some larger issue of science denial just in the world today, and especially in America, and sometimes we would rather people not have access to what really is evidence-based to be the best thing that's for them because of that stigma. And so we have a lot of work to do to educate people on what medication-assisted treatment is or other interventions that are evidence-based, because people have feelings about those interventions, and they think that it's encouraging drug use or there's some kind of judgment and moral issue, and we really need to get away from that and really fall on what we know is working. And so being able to offer the medications and also, fight that stigma against the medications, educate the public, let people know what their best chances are. Caleb is definitely one of our best advocates out there talking about cutting overdose risk. It's really important.
Brad, you're the co-chair of the task force. Your take on these past 2 years, just as we've tried to deal with this issue. 2 years ago, I think we were kind of, in the midst of saying, what is going on here?
Yeah, I think you hit it right on the head. I mean, I remember when the task force started 2 years ago, and we didn't know what to do. I mean, I'll never forget that first task force meeting when there was over 40 people sitting around the table, and that first time people went around and did introductions, and people saying, this is what I do, and this is what I do, and this is what I do. And everybody was alone in isolation trying to fight this uphill battle. And one of the amazing powers of our task force was coming together in collective will, but then also coming together with some comprehensive strategies. And I think the 8 strategies that the task force put forth are strategies that are not going to solve the problem overnight. But what we can do, and what we have done, is we've started to build the infrastructure, like Caleb was saying, like Theo was saying, to start to implement the strategies that we know work, because there's a whole lot of evidence about what we know that works, and in a way in which people will receive them. A good example of that is this last December, we reopened up a detox facility here in town that had been closed for a number of years. Now, traditional detoxes and that facility historically was a very abstinence-based, had a very abstinence-based modality. That's what they preached, that's what they practiced, that's what they tried to do. We've been able to integrate buprenorphine treatment, a medication-assisted treatment, when people come in to help stabilize them, because we know actually that when somebody goes into detox, it could actually increase their risk of lethality and death on the back end, because if they're abstinent for a short period of time, they come back out. I heard a story about it tonight. Somebody was abstinent for a short period of time. They came out and they overdosed and died, and they almost died 2 weeks later. So we've been able to take interventions that we know work and implement them in our community.
Buprenorphine does explain that.
Yeah, so buprenorphine is a medication-assisted, it's a medication that treats opiate use disorder, and what it does, it's a partial opiate agonist, so it partially acts as an opiate and fills the opiate receptor cells, and at the same time is able to kick away and rebuke opiates that somebody might on board. And so what it does, as Caleb was talking about, is it decreases the risk of lethality by 50 to 80%. The other thing it does that's amazing is it takes people's cravings away, right? Because from my experience, my experience with family, my experience with people that I've worked with, is that people don't like being having opiate use disorder. They don't like the cravings, they don't like the urges, and Thea can tell you a lot more about that from her work at the Needle Exchange. They don't like being sick, and so being able to treat that with a medication that keeps people from craving, wanting, urging, and seeking drugs is extremely effective.
Rob Johnson, let me ask you about what you hear from your constituents on this issue. I imagine you get an earful.
You know, not as controversial as something like bike lanes,
Really?
okay, but certainly something that people want to talk about. You know, I'm at the University District Farmers Market every Saturday morning from 10 until noon, and it's a place where people can come and ask questions about what's happening in City Hall, or just feel free to give me unauthorized opinions or authorized opinions. And, you know, when folks come and talk to me about this, I would say 2 to 1 in favor of a different approach than the approach that we're taking right now. Because folks are seeing needles in bathrooms, they're seeing needles in parks, they're seeing needles in outdoor spaces and in indoor spaces. And they recognize that what we're doing isn't working, and so they're interested in other approaches. There's also fear and anxiety, healthy mix of fear and anxiety with some of those folks too. But once you spend some time educating them about the real benefits and the opportunities that we've got in front of us to treat people as human beings, it really is amazing to see the empathy that folks have and their willingness to follow a public health approach.
How do we deal with the fear and the anxiety? Because if you go and people are seeing needles somewhere, and right away it freaks them out, and if they see somebody downtown, what do you tell them?
Well, I think it's really important to acknowledge that addiction is frustrating. And it's frustrating for everybody involved. And I think that's what people need to understand. It's frustrating for you to be addicted. It's frustrating for a family member. It's frustrating to see it in your community. I run through Lower Woodland with my dog every day, and I see people struggling. And it's dispiriting to see that, to see people really struggling and living outside and injecting drugs in an unsanitary way. And I think what's important is to acknowledge that frustration and to also recognize that there are things we can do about this. This isn't as though we don't know what to do. Poor Brad. When I showed up at the task force, I showed up with a little graph of the 70 things that we can do. We have a big toolbox. We actually know what to do and we know what's effective. So I think what's important is to hear what's going on in people's communities, let them know, hey, here's a toolbox of things we can do. Here's the differential impact they can have. If you want to keep people from dying, you can do this. If you want to prevent this problem from happening in the first place, you can do this. You have some power. So people feel powerless when they see this. And I think when they learn that opiate use disorder is a treatable medical condition, and I think also understand that, yes, it is a medical condition, but it also is about people having an emotional relationship with the drug as well. There are really two sides to that, and that you need to address both of those things, that we can do that, and that you can transform people's lives. I remember I was in a meeting in one of the neighborhoods, and I said, well, if you're going to put X facility here, then we need another library to make up for it. I'm like, I think if you actually got to sit with someone and watch their pretty quick trajectory from a life of really out of control use and into recovery, which with medications you can start seeing major transformations within 2 weeks, I think you're going to get a lot more than some amenity like another building. I think really seeing people's lives transform, seeing people come back to themselves. So it isn't just about saving lives, it's about bringing people back to who they are and were. It's transformative, and it's something that I think people want to see. I think they're fearful of it. The challenge with addiction that I have found in my conversations with folks is that we're all experts because we've all been impacted. The problem is that we're mostly wrong because we don't have a good evidence base. We don't understand what actually is effective and what's not. We've seen what has or hasn't worked in our family, and then we generalize that to the entire public. We don't do that with chemotherapy drugs, but we do it with addiction because you look at it and it looks like a person making a bad choice. Why is that person picking heroin over their kid? That doesn't make sense. And it does make sense when you understand the brain chemistry, when you actually understand that people's brains literally change, that the priorities in their life change, that they don't want to live that life. Yeah, you know what? Those young adults may be looking like they're having fun. That's what young adults do. It's not that they're actually having fun. They're putting on the airs because that's what they're doing. They're not happy. They're not doing well. They're struggling. And if you offer them the right tools, they will happily grab them. What we found out with these new treatment programs we set up, the programs were full in 12 weeks. People were lining up 2 hours early, sorry about that, outside of their clinic to get treatment medications. To say that people don't want treatment is entirely incorrect. If you build the right services for people where they can access them, they will come.
Brad Finegood, this is really personal for you because you lost a brother.
Correct. Yeah.
Tell me more.
Yeah. So, it is personal for me. When I was 29 years old, my brother, who was 26, died of a drug overdose. And, you know, what I'll say is that I had been working in this field for a while, which, you know, led to a lot of, I mean, obviously when a loved one, your best friend, you know, the person who you spend time with and talk with every single day dies, obviously it brings a lot of feelings and a lot of emotions and takes you on a really difficult life journey. But what I can say is that, you know, the thing that I've came to the realization about is that drugs didn't kill my brother. It's stigma that killed my brother. It's the way that we look at people with substance use disorder. It's the way that we look at people that have mental health conditions. It's the way that we talk about people and the way that we look at people, because if I think I'm worse off or if I'm a bad person because I use drugs or I have a mental health condition, or if my family member does, then it's just gonna keep us in silence and perpetuate the disorder. And as a community, how we talk about people with substance use disorders further perpetuates that stigma. You know, when we have interventions that we know work and we choose not to use them because of fear, that's stigma. That's discrimination. And so in this journey of mine that's been 14, 15 years since my brother passed away, there's been a lot of realizations. But it's not that my brother was a bad kid, because he was an amazing kid. It's not that I was a bad brother. It's not that my parents were bad parents. It's that silence, stigma, and discrimination kills people.
Yeah, you've been there.
Yeah, I'm an overdose survivor. You know, thankfully, in the time that I was homeless and using heroin in Seattle, there was all of these robust harm reduction services, and I had relationships with needle exchange staff, and I was accessing treatment. I was always like in some process, but there were always multiple steps to every type of treatment. And so depending on which appointment I was waiting for or which appointment I missed, because those things happened a lot to me, or which appointment I was trying to find a ride to, that kind of thing. There were a lot of times when I had to start processes over, and there were times that I would get into treatment and it wouldn't be successful for me. And so I always found my way back to needle exchange because I had this one space in which I never was judged for my drug use. I was always welcome back. I never had to feel bad, even though of course I did, because that's the nature, you know, the shame is part of the disorder. And so for me, I had this like wonderful resource and people that cared about me, but unfortunately, I would pick up supplies and go and use in a public space because I didn't have any better option. And so I overdosed in a public restroom. And thankfully for me, someone found me and was able to call an ambulance, and I had Narcan and all of that wonderful stuff, and I'm still here. But I definitely can relate to being isolated. And even though my family knew, I felt completely alone. And so it's really important that we do everything we can to let people know that they're loved and they're worthy, that we idolize compassion over everything else. I really don't think there's anything as compassion fatigue. Like, you can never get tired of feeling compassion, right? We get burnout in our work, but there just shouldn't ever be an end to love or compassion, because that's the undoing, right? When you're addicted, you've lost connection and you've lost the ability to make, you know, choices for yourself, and everything is sort of unraveling. And when you have somewhere where you feel safe and supported, that's where like building happens again. And for me, you know, harm reduction work is so important because that is where I began to recover. Long before I was able to stop using, I was starting to recover a sense of myself as someone who is worth something, because there were some people who thought that I was important enough to care about. But, it isn't that easy. And treatment isn't, recovery isn't this straight line. Like, here I am, I have opiate use disorder, and then I got treatment, and then I never turned back. This is a long-term chronic relapsing medical condition. And so we need to make sure that we have types of care that meet people where they're at all along that continuum. And my hope for everyone is their best, healthiest life, right? I want people to be happy and to be healthy, and sometimes that's going to be in little teeny tiny increments, and sometimes people are going to recover incredibly quick. But we not only need to provide treatment, we also need to provide safe and loving environments for people to learn to grow. I see Oxford House is in the house, and back in my day, I lived in an Oxford House, and that was huge for me to have a community, to have people that were there for me 24 hours a day, because I didn't come in to heroin addiction without mental illness to begin with, and I certainly wasn't going out with it without bringing it with me, and so there were a lot of times when I was struggling, and sometimes I think that the support that I had isn't really available to everyone. I'm really grateful that these guys in the room have done a lot of work to make sure that medication-assisted treatment is welcome in Oxford House, because I think that it's really important that we recognize what works and also how we can incorporate that with other stuff that works.
Caleb, but we still have a big problem. And 2 years ago when we talked about this, we were seeing this thing just start to really, it was already there. Mm-hmm. Why? Why do we still have this problem, and why can't we get a handle on it?
I think what's important is, we're talking about opioid use disorder, we're talking about substance use disorder, but I think the broader way to see human beings with those issues are vulnerable people. And what do we do as a society for the most vulnerable people? And this city is struggling with that right now. As a lifelong Seattleite, we have a city in conflict. And we have a lot of poverty and we have a lot of homelessness in our city. And that creates a lot of vulnerability. I'm not an expert on homelessness, but my understanding of homelessness is it's primarily driven by poverty. You can't afford a place to live. And I've never been homeless, but I'm pretty sure that if I was trying to sleep in that rainstorm on Saturday with an empty belly, I might have a little bit of anxiety. And I bet that as that kept adding up every single day, it would perpetuate and get worse and worse, and my ability to be able to do good reality testing, know what's reality around me, might get distorted. So I think what we're really talking about is a society that has people who are vulnerable. Substance use disorder is a manifestation of that. And so we're trying to target substance use disorder as a thing to fix, but that's trying to fix the problem. It's not trying to fix the root conditions that are causing it. So substance use disorder is just one way that we manifest distress in society. So we're trying to treat this back end of it, but it's a lot bigger problem to fix all those other things. And we're trying to do those things also, but those are big societal shifts. And we're talking about a huge population, tens of thousands of people in our community who have a substance use disorder. And that's going to take a long time to sort of change the direction of that ship. So we're nipping at it, and we're making real meaningful progress, and we're basically piloting brave new ideas and ways of doing things. And now I think we're saying, wow, these are working. What's it going to take to scale these up to serve everybody? But we're essentially, again, we're trying to fix the back end of this, and that's not the way to solve it, because we also have to address these root problems as well.
So is the city really prepared to deal with this, Rob Johnson, and get a handle on it? Or...
I think so. We are making our way towards funding in conjunction with the county, standing up our first safe consumption site in the city. That's just one of the many different ways that we are working to help treat folks with opioid addiction. But it's an important one. It is, I think, going to be a really great first opportunity for us to find ways for us to grab people who are feeling afraid and alone and vulnerable and get them into a safe space and build that trust and those relationships with folks so that on the day that they want to get clean, that they have that ability to get assistance when they need it. I think that for us as a city, we are tripping over ourselves to find ways to finance more safe consumption sites throughout the city of Seattle, because one of the things that these experts will tell you is that folks are using what they're using. And when you set up something in one neighborhood, it doesn't necessarily mean that you're going to have people from all throughout the city gravitating towards that neighborhood. We need to have a geographically diverse set of treatment facilities that can treat folks throughout the city. And I think we're in a unique position because I've got 8 other colleagues and a mayor who are very supportive of a geographically diverse base treatment. And what we really lack is enough resources to stand up those treatments, particularly in the light of all of the threats coming down from the U.S. Attorney General.
So you know and I know that not everybody's thrilled about some of this. And I'm sure we'll hear that tonight from some of our audience here. It's particularly the issue of safe injection sites. I can understand people saying, we don't need these. This is only just aggravating the problem and making it worse. What do you tell them?
I tell them a couple of things. One is, clearly the solution that we are trying right now isn't working. That's why you're seeing so many needles in parks. That's why you're seeing so many needles in bathrooms. That's why you're seeing so many needles throughout the city. And one of the best ways for us to address that broader public health crisis, and believe you me, there's nothing scarier than the moments we have found needles in our front yard. I've got 2 7-year-olds and a 4.5-year-old. They don't know anything from needles. And when we find those needles in our front yard, it is a scary moment for my wife and I. But I also know that one of the best ways for us to get folks help is for us to take a public health approach. I'm a policy nerd. I'm an urban planner. I've got family who are on the walls here at Mohi because I'm a 5th-generation Seattleite. We're a city that is famous for innovation. We're a city that's famous for progressive approaches. And this is a moment where we need to look ourselves in the mirror and ask, what are we going to prioritize and how? And I think we, as a city, are looking for ways to really treat people with respect. And this is one of the best ways we can do it.
I want to turn to Johnny Schilling. Johnny, can you come on up here and stand by me? He is with LEAD. LEAD is the Law Enforcement Assisted Diversion program. That is, it is a pre-booking diversion pilot program developed with the community to address low-level drug and prostitution crimes in Belltown, as well as a neighborhood in Seattle, Skyway area, unincorporated. It's actually been looked at nationally for its work. You're a supervisor, but you're also a case manager. You see what's happening on the ground and in the streets here. Tell me what you see and how is it?
Well, there's a lot there. First, I'll say we're not a pilot anymore. We passed that phase.
Okay.
We're official. We're official. There's been studies. There's lots of research that came out of that.
That was 2 years ago.
Oh, that was more than 2 years ago. But regardless, there's lots of good research that came out of that pilot that really gave us a lot of really amazing information to work with, right? And how LEAD works, right? We are a pre-booking arrest diversion. That is correct. And how people can come into the program is by having interaction with law enforcement. Law enforcement says, you know what? Would you like something different? Would you like to do something different right now? Person says, yes, I would. This actually is no fun. And they call us. We come, we do a screening, and that person walks out with us, right? There's nothing more exciting than to be able to go with that client out of the police precinct knowing that they don't have to spend that night in jail and they don't have to face that felony just because they got picked up using or selling, right? And LEAD is for life. You have to work really hard to get exited out of the program as a client. You have to work really hard, right? We stick with people, not just until they get treatment, not just till they get housed. We stick with people, right? Because as Thea pointed out earlier, this is a long road, and there are lots of bumps in that road, right? And we know that recovery isn't something that is static, right? And so we walk alongside people and we say, what do you need right now? You don't need anything? That's okay. I'm gonna call you back in a couple weeks and say, hey, how are you doing today? right? So LEAD, I think the unique part about LEAD is that we take people whether they're housed or not. We take people whether they're in recovery or not. We take people, really, if you agree to be in LEAD, we'll take you. And the only underlying factor there is saying, yes, I'm using right now. That's it.
What do people tell you about why they use?
I mean, goodness, that's also a very big question, because everybody comes at it from very, very different aspects, you know? Caleb pointed out earlier that use stems from sort of that vulnerability, that trauma and that unwillingness to face that anxiety, inability to face that anxiety by yourself. You need something, right? Everybody needs something. We just don't all have the same things to deal with it, right? And I think one of the big aspects about LEAD and how we operate, how the case managers operate, is that because we're so outreach-based, we go out where the client is, whether they're in housing, whether they're under a bridge, whether they're at a city-sanctioned encampment. We go out to where they are and we say, how you doing today? And treatment is never a string that's attached, because we work with people until they're ready, if they're ready.
Is progress being made?
Absolutely. Absolutely. I mean, if you just look at the sheer numbers of people that we have enrolled and the level of recidivism that has decreased purely based on their enrollment and having that touchstone with case management to say, because some of our clients, they don't have the family members to fall back on. They don't have even friends to fall back on. They are alone, right? And having that connection, having that touchstone of a case manager that says, you know, John, how are you doing today? Maybe John hasn't spoken to anybody in 2 days. People need that connection, right? That lack of connection is what really fuels use. That lack of human connection and the compassion and the love that you get through that connection.
Thank you.
Yeah.
It seems that as I look at the recommendations and the challenges along with it, is that treatment and finding treatment for people is still the big challenge here.
Yeah, I mean, I think that's one of the places where we've made the greatest amount of progress in the past 2 years, because no matter how you feel about some of the other recommendations, most people talk about we need treatment, and we need more treatment, and we need treatment on demand. So now, we can get people on medication-assisted treatment usually within a day or two. We can get people into detox same day, residential treatment and outpatient treatment within a day or two. So being able to strike while the iron's hot, and as Johnny said, when people are ready to make that change, we have to have access ready in a way in which they'll accept it, is really important wherever they're at in the continuum. One of the other things I'll say real quick, Enrique, that we haven't talked much about tonight is about prevention. And that's something that we've spent a lot of time and a lot of effort on, because one of the facts that we know that continues to ring in my head is 4 out of every 5, according to the American Society of Addiction Medicine, 4 out of every 5 new heroin users, so 80% of people who start and initiate on heroin, start with inappropriate use of prescription drugs. So not that everybody starts there, but that we know that there's a pretty clear pipeline into illicit drugs. And often prescriptions become illicit, or people take them inappropriately. And we've done a lot of work in the medical community over the past year and a half. I see some doctors here in the audience that have been just huge advocates, because pain is not an emoji, smiley face to frowny face meter. we need to be able to understand that pain is a condition that we live with, and how we treat pain is really important. And then there's other prevention things that we've rolled out. The other thing that I think that I'll say real quick about stigma is that when we started our task force, we took an equity and social justice pledge, and we knew that we needed to look at the drug use epidemic, not just at opiates, but we've been treating and working with people for the past 100 years with a very criminal justice laden approach. And what's that done is it's decimated communities, and especially communities of color. And so when we do this work, I look around the room, I look on the stage, and we need to make sure that we focus on really the communities that are impacted. And if we don't do that, then our propensity to cause greater disparities is very dangerous in our community.
Let me turn to Carol Ann Sanders. Carol Ann, come on up here. She is active in her community on harm reduction approaches to substance use. She holds a master's in community-oriented public health practice from the University of Washington. But she also has, you brought up the issue of, I think, social justice, racial justice, and how this is viewed. And you have some deep concerns about this epidemic and how we look at it, and particularly from a criminal standpoint.
Yeah, absolutely. I think it's just important that we make sure that the conversations that we have about our approach to the opioid crisis are not divorced from past approaches that we've taken to the larger issue of drug use. I think many times these conversations frame the opiate epidemic as sort of a crisis the likes of which we've never seen before, but we know that that is in fact not the case, right? And there's some research out there right now that suggests that actually cocaine-related deaths in Black communities are on par with white deaths from opiates. And so we also know that, 40 years ago we saw a heroin epidemic, much like what we're seeing right now, but as Brad alluded to, the response was very much one of, tough on crime. We saw things like the Rockefeller drug laws, which started in New York and really set the national tone for how we decided that we were going to confront the issue of drug use. And it also painted a picture of the predatory Black drug user who deserved, these mandatory minimum sentences, these lengthy prison sentences with no possibility of parole or probation. And so it sort of begs the question, what's changed? We know that the drug use hasn't changed, but our approach and our response and the way that we talk about the issue has radically changed. And it's relevant to this conversation today because we know that the compassion and the urgency and the thoughtful deployment of public health resources that we see now are not how we responded to Black and brown drug users. And so I think my question for all of you today is how do you grapple with this in the work that you do? We know that communities of color are contending with multiple layers of trauma here. There's the trauma of addiction and of problem drug use, but there's the overlay of the trauma of the criminal justice system and the foster care system that absorbed all of the children whose parents were sent to prison because of their drug use. And so when it comes to policy or research or direct service, how are you centering those communities in your work? Because, I think if we strip it down, what we're really talking about today is using policy and using direct service as a way to recognize the humanity in people, right? We're saying we all have issues, we are all broken people, but we're not going to stigmatize you because you choose to cope with your life through drug use. I just wonder, why are we so willing to extend that compassion when it's white opiate users who are front and center in the media, but we weren't willing to extend that same compassion to Black and brown drug users in the past? And we have to remember that this is not a previous issue, right? Like this is not a chapter of history that we've closed the door on. Like there are still people languishing in prison today for the very same actions that we are now calling a public health crisis. So what do we do? What do we do to grapple with restorative justice in that way? How do we bring that in?
We've been there. So how do you respond to that?
Well, So my favorite quote is Richard Pryor saying it's an epidemic when it happens to white people. So when you talk about drug use, it's an epidemic when it happens to white people. And we saw it in 2001 when I started working on methamphetamine use, and we hadn't been talking about what was happening with cocaine at the time, and that's because of where methamphetamine was hitting. It was hitting rural white areas. And we see the same thing with pharmaceutical opiates in the end of the 2000s when we passed Washington State's Naloxone and Good Samaritan law. That law passed on a 6th time around, I think because you're able to get those rural legislators who are concerned about their people on board. So part of it is just calling it out when you see it. That's a piece of it. I think the other piece is making sure that we're getting services to the folks who need it the most. And when it comes to opiates, Native American, Alaskan Indians in our state have a 3-fold higher rate of opioid overdose, far and away over anybody else. And so a lot of the work that we're doing are with tribal communities. So we're doing in tribal communities all around Washington State, and then within King County, working with both the Cowlitz Tribe and Seattle Indian Health Board to create these low-barrier buprenorphine treatment services. So we got to talk about it and call it out, and then we got to pay for it. So those are the things that at least that I'm involved in.
I think it's important, first and foremost, to acknowledge, right? Because a lot of times we just sort of breeze by our history and we don't talk about the damage of the drug war. I don't know that I can necessarily fix a whole lot, but I know that when I'm looking at data, I'm looking at not only how many people are getting into treatment and staying there, but what do those people look like? And so I am trying to examine, is your housing status related to whether or not you're getting served in the treatment systems that I'm sending you into? I'm also looking at race. Is that a factor? Is that a factor in treatment retention? Because I think that it's really important if we're going to be providing care that we know what we're doing well and we make sure that we're not just doing stuff well for white community, right? It's really difficult because, yeah, it's not over, you know, for families who have had generations of people sacrificed to the drug war, and now we have this brand new white and shiny approach that we want to sell. And I think that some of the task force work, and Patricia Sully's here in the audience, she really pushed for, with our recommendations for supervised consumption spaces, that we offered space for smoking, because that could be something that had a racial component, and she wanted to make sure that we were not creating something for this group over here while we left this other group over there to end up with criminal justice interventions. And I think that the more that we have people making sure, using that lens every time we're designing an intervention, say, hey, what are the equity and social justice implications of this? What have we not come to? And go to communities of color and invite them to the table. I'm sure you see who's on the stage here today. We need to make sure that we are inviting communities of color and not just, hey, you, person of color, we need you to sit on stage so we look like we're being inclusive, but really to find out who the experts are in communities and find out what they know and what they know that works, because communities know what they need most of the time, and so that's where we really need to be focusing our eyes and ears.
What do you want to
add? So I'll never forget the first time I ever walked into a prison, right? And I walked in I was working there that time. No, just joking. I walked into prison to run a group, right? And I walked into this room, and there was 12 African-American men sitting around the table and me. And I mean, there is nothing more stark than looking in the mirror that day and saying, what's wrong with society, right? So I'll never forget, another group I ran there had 12 men of color in there, and I was the only white guy. And I asked them, I was like, how many years collectively, because they're all old timers, how many years collectively have you spent incarcerated? And between the 10 of them, there was like 120 years of incarceration between them, off and on throughout their whole life. And then I was like, how many children and grandchildren do you have out in the community? And there was like a couple hundred, right? And so you think about the systemic effects of our drug policy on communities of color right there, and what that showed me that day, about taking male role models out of the community and leaving children without that healthy attachment. To me, that was one of the starkest moments of my life. That didn't answer your question. What I can say is that the great Dr. Jim Walsh, who's over there, sent an article early on in our task force to some of us about the disparities in medication-assisted treatment access between buprenorphine and methadone, right? People of color had a large access to and utilization of methadone, where white folks had buprenorphine. I mean, that's a great example of how drug policy, right? Because one drug you can get one way, one drug you can get another way. And that also came out of the heroin epidemic that affected communities of color 40 years ago, because there was no way they were going to let doctors treat those people in the doctor's office. They were going to make them come to standalone clinics. So that's guided a lot of our work about making sure that there's access and ample access geographically to where people are at, and really working with different communities to make sure that access is available. Just one example, lots of work to do.
Good. One thing I want to say is that if others have questions or comments, come on up here and just kind of make a little line, and I'll get to you. So come on up. Don't be shy.
I'll just end with one challenge to you all, to just put it upon yourselves to make sure that every conversation that you have about expanding access to treatment also includes drug sentencing reform. The county is doing incredible things around expanding access to treatment to folks who are incarcerated. Critical work, but it's ridiculous that people are even incarcerated for things related to drug use in the first place. And so we have to talk about actually getting people out of jail and prisons who are serving time for drug-related issues.
And I think to that point, we were having a conversation yesterday. I mean, I think what's really important as society is to understand that this is all on a pretty narrow continuum. You need to remember that alcohol used to be illegal and heroin used to be legal. These are just choices we made, and enforcement follows those choices, so we can choose something different if we want.
All right. Got a question here? Come on up.
Yeah, I want to make a comment and a question. Okay.
Don't ever take the mic from me.
Okay. Okay. Hi, my name is Elizabeth James, and I'm from Speak Out Seattle. I am the mother of a daughter who has cleaned now for 13 years, and I have an ex-husband who is still struggling with opioid addiction, and he went on buprenorphine in 2004. You still need the wraparound services to help support that recovery. It's not just a drug that works. It's not a miracle cure. There's counseling and there's other supportive services that are needed to keep someone clean. I wanted to point out I'm against the drug. I'm for everything. Our group is for everything in the opioid task force recommendations except for the drug consumption sites. And the reason why is because they have a very low rate of leading people to recovery, 2 to 4%. If the idea is to get people to recovery, we should have those resources for recovery in place first, and we don't. Last fall, I went to the hearing where Dr. Bantagreen talked about 78% of the people that had done this poll had wanted help getting treatment, and 58% very much wanted help, and 20% somewhat wanted help. And the funding for that last year was for only 100 people, $105,000. Counter to that was that people would only use a drug consumption site, 39% would only use it daily. We know that if you're addicted to opiates, you need them daily, and the rest of the time you're going to be at a very high risk. So
for you, is it all about having treatment?
Yeah, we need to support more funding and widespread funding for the buprenorphine and other medication-assisted treatment. But we only had, from the city of Seattle, $1.82 million spent on any kind of prevention, detox, or even treatment in 2017. I haven't gotten the 2018 contracts yet. So if the cost to run one drug consumption site with 10 rooms, 10 hours a day, 7 days a week is about $4 million a year, we really, really need to have the resources to get people the treatment that we're hoping to connect them to in place first. So.
Can I have their response? Thank you.
Yeah.
Can I respond?
Anybody want to respond?
Yeah,
Go ahead.
I'll start real quick. So I just wanted to thank you for sharing your story. I mean, there's nothing more powerful than sharing your story and about what loved ones have experienced. I mean, that is really the first step to destigmatizing this opiate use disorder. So, I mean, there's many other things that I can say in response. So the 2 to 4% detox rate, insight is, so the way that, it's people who started using supervised consumption space after they started using, there's a 30 to 50% treatment uptick rate. The way that Insight works in Vancouver, BC, is there's a detox upstairs with only a finite number of beds. And so for people to get in, it's not, what we defined and what we decided here locally is that isn't the model that we're looking for. We're looking for a treatment on demand model that we're going to build as part of this, where people can get access to treatment right then and there. It's a different type of treatment because detox probably isn't the best intervention. So that is that's to be considered. Also, just to what was said about the city's contracts about a couple $1 million a year, that's actually the county responsibility. So the county, my office, is the Medicaid responsibility, and we spend hundreds of millions of dollars on treatment, on substance use and mental health treatment. The treatment resources are there, and we're working on making them better, and we're working towards a system of treatment on demand. With people with opiate use disorder, we're pretty darn close. What Councilmember Johnson said is really true. It's about geographic representation, right? So if I'm in a square block radius, I shouldn't have to travel far to get treatment. I should have treatment close in, and that's what we're working on. We just turned out another $500,000 of treatment resources to expand upon the innovative model that we've been able to do at the Downtown Public Health Needle Exchange. Over this past year, the task force and task force members we've stood up 40 new treatment access points around the county. We want people to be able to get treatment as easy and as possible when they're ready to get help.
Anything you want to add?
Nothing. I'm not the budget expert, but I will say, our little $1.5 million that we're trying to put into safe consumption site is a drop in the bucket compared to the hundreds of millions that the county is spending on treatment and recovery issues. And we need to do our part. But I think I was kind of joking, but if you actually look at the public opinion research on this topic, I mean it seriously when I say that bike lanes on city roads are more controversial than opening up safe consumption sites in neighborhoods. It is more difficult for me to go out to neighborhoods and talk to them about taking away parking to put in bike lanes than it is for me to talk to folks about setting up safe consumption sites. And that's a question, therefore, then about our city resources and collaboration with the county.
Okay, go ahead.
Hi, my name is Paula Becker. I want to thank you all for being here, and thank you for pushing this issue, even though people want to talk more about bike lanes. I appreciate that. I am here because of my experiences as the mother of Hunter Brown, who moved here to Seattle at age 1.5 into what became Rob Johnson's district. began using drugs at Roosevelt High School at age 15, eventually fentanyl, eventually heroin, and died last summer. And I want to say to you that I hope you never find yourself in this position, Rob, but if you look 10 years in the future and imagine, God forbid, your 17-year-old is using drugs and you've got two 14-and-a-half-year-olds in the house, that was basically where we found ourselves. And I want to say, this is a family problem, too, particularly for those of us who have a child who begins to dabble in this and become enchanted by it at an early age, particularly if you have younger people in the house. And I would like to know what Seattle and King County is doing to support the families of young people with addiction.
Do you feel like you're not getting the support you need?
Well, my son is dead, so my need for the support is gone. My other kids are older, and thank the dear Lord, the choices that we made so far seem to be okay. Our youngest is a sophomore in college now. But during those 10 years that we dealt with this problem, we felt almost no support. There's a huge breakdown between what the high schools can do, and I know they're understaffed, I understand that. But truancy is a piece of this, and identifying this problem early on is a big piece of it. And at least in our situation, at least starting about 10 years ago, I didn't feel like there was enough being done. I would love for other families not to experience this the way that we experienced it.
I just want to thank you for sharing this.
Thank you.
Yeah.
Can I spend a quick minute on that? So I'm going to nerd out for a quick second with you about budgetary issues. The state has the basic responsibility of funding our education system. And one of the ways that they fund education is they've got a specific formula about what they define as basic education. They plug some numbers into a formula and they spit out some of the ways that we as a city, as a school district, get those resources. To give you a perfect example, the state's definition of basic education support for our 54,000 public school students in the city of Seattle is to give us 9 total nurses. 9 nurses total for 54,000 students. The city of Seattle's Family and Education Levy funds 26 clinics within elementary, middle school, and high schools throughout the city. We have a levy that is up for discussion this year and hopefully will be on the November ballot. And one of the things that my colleagues on the council and I are talking a lot about is how do we provide more wraparound services within that levy, not just for public health medical treatments like dental treatments and other simple things that nurses are providing within public schools, but also really wrap around mental health services too. So we've got a large number of students experiencing homelessness in our public school system right now, and many of those families are not getting the necessary case management support in other ways that they are getting at schools in a place where they're trusted and they feel supported and valued. So I think that there's a lot of ways that we as a city are trying to really provide additional support and services, and doing it, again, not just in collaboration with the county, but in this case with the school district to provide more resources for families.
That's great. I want to say one more thing. It's also a problem for those of us who aren't experiencing homelessness. Hunter's father, my husband, is a doctor. We had every resource. We had medical insurance, and parents should not be having to Google away at 2 in the morning looking for the first, second, third, fourth, fifth rehab that they try for their kids. There should be something more to help us. It's a big societal problem. A lot of parents, all parents, I think, want that help, so help us.
Isn't that the challenge, though, for just so many people to, once you get caught in a situation?
The Recovery Helpline has a opiate-specific resource tool nowadays. You could probably talk about that better than I can.
I'm aware that it's developed probably since 10 years ago. I hope so.
So first I want to acknowledge your loss, and I'm incredibly sorry for you. I have 2 adolescent boys, 1 at Roosevelt. So I can empathize. I want to talk about the Recovery Helpline at the back end of this, but just describe the 3 pieces around the prevention components of the task force. And none of this is magic, right? This is sort of big societal shifts we're talking about. So one of the big societal shifts is rethinking what is pain and stress and how do we manage it, right? So people have heard me talk, hear me on my soapbox all the time about we think there are quick fixes for distress, whether it was diet chocolate cake when I was in high school, or whether it's OxyContin now, or whether it's Valium, right? We think that we can reach for something outside of ourselves to fix distress. I'm also mindful that my kid who's sitting in mindfulness classes at Roosevelt is not loving it. Not his favorite time of the day. But I think we are trying to rethink, what is the right instinct? And so one of the things that did come out, actually in parallel, the state was doing work, or some educational materials intended for parents and for adolescents who have pain. We spent a lot of time at the state level trying to rein in opioid prescribing without dealing with the fact that we're not addressing demand. And that people think that if you're in pain, use opiates. That's sort of the natural thing you learn. Oh, I broke my ankle, I need Percocet. Like that's our natural instinct. Or I have a tooth extraction and I need Vicodin. So that's not actually normative. That's not what most of medicine says. So there's been a lot of educational materials that are coming out that are getting pushed out to say, we have a big toolbox about how to treat pain, acute, moderate pain, and opiates are the bottom of the toolbox. They're there if you really need them, but they're really at the bottom of the toolbox. And if you do bring those medications in your home, bring as few as possible, lock them up. The day you stop using them, dispose them. Dispose of them immediately. Not eventually when you remember to, immediately. And King County has over 90 pharmacies where people can get rid of their meds. So that part's really important, and it's to also help parents frame a conversation. And when I've been talking with kids' middle schools, is to have those conversations about when and why it might be safe for a parent to take a medicine and not for a kid. That just make that a normative conversation. Think about all the things we talk about around motor vehicle safety and seat belts. We don't talk about that around medication safety, and we should, because the hazard is at least as big. So there also is, just quickly on a task force, is encouraging providers to use the prescription monitoring program to actually look at what other medications people might be using and try to reduce the diverted supply. And then trying to support better screening and brief interventions in schools around opiate use disorder. So trying to educate people on that. Yeah?
I would say also about anxiety, because the way that a kid manifests anxiety at school is very different from the way it manifests at home. When you you want to make it normal at home. You don't see that. The kid doesn't show you what they're showing at school. So I think the schools could be very important in early intervention, because social anxiety is one of the things that predisposes kids to start experimenting with drugs. That was certainly in our case. Wish we had realized it as early as it happened. I think
learning how to manage stress and building up your own toolbox for that is really important. And then what we're working on doing right now with the Washington State Recovery Helpline, because here's the problem we're trying to fix. And I've sat in on these calls with the Recovery Helpline. A mom calls in about their teenage son. Mom, teenage son, typical. That's the typical pattern. I need to get my kid in detox. Who's your insurer? Where do you live? Here's where detox is. We've now changed that conversation to say, I want to let you know that detox is not complete or evidence-based treatment for opioid use disorder. It can actually induce harm. It can cause an interruption in tolerance. When they come back out, they die. So what I've learned and talked with the general public is the general public has a misunderstanding. This is about us not actually being experts. They think that treatment for addiction and opioid use disorder is detox and inpatient. Those are in fact contraindicated. What parents want to do is rescue their kids and put them in a safe place, and that feels like a residential treatment facility. But unless they are offering the full array of treatment medications, they're not doing evidence-based care, and they're increasing harm. So Recovery Helpline is now able to have those conversations with folks, and with county funding and with some state dollars that I'm working with, we're actually building a treatment directory that's actually useful, that actually tells you where you can get treatment today in a drop-in way for a person who's homeless and who uses cocaine. Like not for the person with insurance who has the only issue in their life is substance use disorder, but everybody else who's got a gajillion things going on that generally interfere with their ability to start and stay in care. So we're working on all of those things. It's not magic. It's not going to happen overnight, but the need is clear, and we really are trying to marshal resources.
Yeah. Very widely. Thank you.
Just real quick, I mean, to your last comment, and also, as a fellow family member who lost somebody, my heart goes out to you. I just want to say that, we made these 8 recommendations with the task force, and it really is a shame that the one that gets the most publicity is supervised consumption, right? I mean, it really is a shame because, as somebody up here earlier said, really what we've spent almost all of our time on is treatment access and prevention. And that's the most important thing, because when people want treatment, and the earlier on that we can identify, the better tools that we're going to have at our disposal. That doesn't mean that we don't need an intervention or multiple interventions for the most marginalized folks, for the folks who are the most vulnerable. But we have to be able to provide treatment when people want treatment. Otherwise, then we'll have a broken system.
Hi, I'm Barry Brown. I'm Paula's husband, Hunter's dad. I've been a family doctor in the state of Washington for 25 years now, 5 years at Seattle Indian Health Board. Part of that time I was co-director of the residency site there, 5 years in the Providence Swedish primary care system, 4 years as a rural emergency room doctor in pretty much every corner of the state, and now 11 years working urgent care at the Everett Clinic. I would like to, you've answered my question in part, but I would like to address specifically the issue of prevention, and I was very glad to hear you say the words emotional relationship with the drug. That is a huge elephant in the room, to use a tired cliche, and I would submit that as destructive as addiction is to people's physical comfort, as much as it can shorten lives, one of the most destructive aspects is it takes away people's ability to maintain loving relationships. And it takes that away from family members too. And there is no worse feeling of helplessness. And so I am really not on board yet with safe injection sites. As much as I am very much on board with harm reduction, I'm very much on board with not making this a criminal justice issue, with making treatment available, with making buprenorphine, methadone available, rehab available. I think that the public statement about the meaning of this drug really matters. Words matter. Actions matter. I mean, all you have to do is see how our president's words are, in fact, empowering ruthless strongmen in countries across the globe. You know, what you say and what you do, even if the amount of people you help, is measurable. If you change society's relationship with the drug and what we, the authorities, are saying is okay, we will stand by. We will stand by while you use. We know it's destructive. We'll stand by. We'll stand by. We'll stand by. We'll make it easier. There is a message there. And society is getting certain things right now that tie into this. The Me Too movement, the understanding that emotional abuse is not okay. People know what gaslighting is. No one used to know that term. You read it all the time. Well, if you want to become an expert at emotional abuse and gaslighting, then you should have an addict in your house, and you'll know. Okay, we say those things are not okay. We say people should push people away who are treating them like that, except when it's someone who's using heroin, and then there is no limit to the amount of compassion you must extend to them. You do not measure the cost to yourself. That's a huge gap. It's a huge vacuum in the discussion. It needs to be brought up. It needs to be understood that there is a reason for the stigma of addiction, because addicts destroy the loving relationships that people have formed with them. They destroy them. It's a choice. I know people feel they don't have a choice. One of the best books I've read on this, and I've read a lot, is one by a guy named Gene Heyman, Harvard University Press, called Addiction, a Disorder of Choice. Free will, it's very complicated. I won't get into it, but he says addiction is a shortcut to satisfaction. I think that's one of the best terms I've heard for that. And I do not wish to stigmatize addicts and make them feel worse, but I do not wish to sweep under the rug the destruction that choice causes to their loving relationships, those they love and the ones that love them. And our message that we send, our relationship as a city with the drug, is going to affect how people feel about it inside and the choices they make. You need to keep that in mind.
Thank you.
Thank you.
I appreciate it.
I would love a chance to respond. Just,
Sure.
First of all, of course, I'm very sorry for your loss. It's really hard for me. to listen to parents because of, what I put my parents through. And when I talk about that unlimited compassion, I'm not talking about in your home and not being able to have boundaries. Because I think that what you do to survive your life, you have to be able to sleep at night, and we all have to survive this, right? And so where I really want there to be that unlimited compassion is outside of those interpersonal relationships. I absolutely forgive whatever boundary you need to have if you have someone in your life who's using and it is destructive to your life. I give you permission to have whatever boundaries you need to survive. I know that it's really difficult. I've been on both sides. One thing that I want to talk about is the things that lead to heroin use or other opiates. For me personally, I always had mental illness, and whether or not people could see that on the outside, it was always there. And I believe that it was organic. On top of that, I had insecurity and trauma and a lot of other things that happened in my life. And definitely when my drug use really, I dove head first and down fast and far, was following some major trauma in my life. Unfortunately, some folks get to cope. We've got a bar over here. And part of what makes heroin what it is prohibition. And so I understand that you don't ever want anyone to take away the ugliness of what killed your son, because it was, a monster in your life. But I think that what brings us to that relationship with the substance, part of it is drug war, part of it is prohibition, part of it is trauma, poverty, mental illness, all of these things, and it's not just one thing. And when we blame the drug, we miss the point. Because if it were just the drug, I could take the drug away and I'd be fine. And I can tell you that I absolutely could not be fine without my drug. And it wasn't that I was getting high, and I could not manage the way that I felt. I had no better tool. And of course, here we are, we want to be able to give people better. And that's what we work on. And that's why we have medications, and that's why we have recovery supports and, drop-in places where you can go and talk to someone when you need to, because we know that it's not just the drug. But part of what isolates you is that it's seen as this other, this disgusting, vile drug. And for some reason, we've managed to make some progress in not stigmatizing certain groups of people with mental illness. We are looking at them with more compassion these days, but an injection drug user is still referred to as a junkie, looked at as garbage. And part of that, I know you don't want to see us let up on how we feel about heroin, but I think that when we focus on how bad heroin is, it's very hard to separate that from the person that's using. And so the stigma that we have toward the drug is connected to the people. And in order to heal, we have to somehow find some worth in ourselves. And it's very difficult, and I'm so sorry. And I love that you both showed up and shared, your truth. I'm sure that it's very painful still, but I think that we really can't miss the point. The drug isn't the thing. It's one of the things. Sorry, go ahead.
Hey, thanks to all of you guys who made that happen, this happen, and who've spoken tonight. The thing that I would love to hear from you guys, and maybe from some of the other folks who have spoken who are working in the field, is if there's one piece of perhaps underexposed knowledge, like one thought or perhaps a myth to be busted, or something either for the general public or for the population of people who are struggling with addiction. And yeah, preferably something we haven't all been hearing for a while. What would that piece of information be?
What I think is really important, and it addresses stigma for people and for treatment, is for people to understand what opioid use disorder is. okay? And it's not physical dependence, right? So we all take opiates in this room every day for a month. We all get physically dependent on opiates. And physical dependence on opioids is a part of opioid use disorder, but the emphasis is on the word disorder, because there's also a psychological component where it's all you think about and it's what you crave, and it literally becomes the most important thing in your life. And you develop an emotional relationship with it. And so when you take physical dependence and psychological disorder, it's going to create social chaos and dysfunction. You can't be a child or a parent or a teacher or a good employee if you're in the midst of all of that. So it's biological, it's social, and it's psychological. So you need to understand it's disorder, it's chaos, all of those things. So I think that's important for people to understand that, because the implication then is that, and I'm not an addiction medicine doc, but so far they've all agreed with this statement, is that the majority of people with long-term opioid use disorder are going to do best on opioid treatment medications for a while. And the reason is they help address physical dependence, and it gets a person out of the roller coaster of opioid use. When you are using illicit opioids, this is your day. You're either waking up and you need to use, and you're stealing something, and you're going to go sell that something, you're going to buy drugs, you're going to use, you're going to be high, and then you're going to come down, and then you're going to repeat over and over and over again. And so instead of injecting a drug or smoking a drug or snorting a drug, if you take an oral medication that lasts 24 plus hours, that at least gets the physical dependence taken care of, so you can deal with the rest of the stuff. It doesn't magically fix everything else, but it gives you a level playing ground to work from, right? I can't apply for a job while I'm literally on a laptop on a roller coaster. It's easier when I'm sitting on a park bench. And so it's as simple as that. And for people to understand that for most people are going to do best on treatment medications, not everybody. People should have the option for all of them. One of the things we didn't talk about in terms of racial and social equity is a lot of the work I'm doing now is for people coming out of prison, because they're generally told, well, they're either going to get methadone or nothing. And it's like, well, no, actually, we have 3 treatment medications, and you should understand the pros and cons of all of those and how you might access those, and that you as a human being deserve to get to make a choice about your own health care. Usually our system, because of race and class, decides for you. So what we're trying to get to is also a place where people have that free will. So I want people to understand it's not a simple thing, but it's not that hard. What is opioid use disorder? What are the most effective evidence-based treatments? To understand that those treatments reduce mortality by 50 to 80%. When France made one of the medications, buprenorphine, widely available that any prescriber or physician could use it, their overdose rate dropped 79%. So it isn't that we don't have the tools, it's that we've chosen not to deploy them.
Okay, good. Just a short amount of time left. They're giving me the hook here. So quickly, let's try to get to everybody else in.
Hi, my name's Jalaire Box, and I'm with Speak Out Seattle, and I wanted to just speak a little bit to the political side. Councilmember Rob McKenna was talking about, I'm sorry.
Yeah.
Everybody calls me Councilmember Rob.
Yeah, you look alike.
Okay, Councilmember Rob, you were talking about how, when you go out to your district, people are saying, well, I'm upset about bike lanes, but King County is bigger than the city of Seattle, and the cities of Auburn, Bellevue, Burien, Covington, Enumclaw, Federal Way, Issaquah, Kent, Maple Valley, Renton, Sammamish, and SeaTac have all voted to ban drug consumption sites from their region. So in that, King County is bigger than the city, and so there's a lot of citizens across the county who have said we're concerned about this particular thing, and I think they deserve to be heard as well. And so we can't represent it as everyone is all for this, especially since the opioid task force has said that they wanted to cite drug consumption sites in an area outside of the city of Seattle as well. And so a lot of people in this room might say that people who oppose drug consumption sites are for the war on drugs. I've heard that. That's not true for most of the people that I know who are opposed to them. We are for so many of the recommendations on the opioid task force, and we're for the medicated assisted treatment at Speak Out Seattle. I'd like to see the conversation extended to what does it mean with substance use disorder in general, where people who are methamphetamine addicts don't necessarily get to use the the medicated assisted treatment, and they need behavioral health care. And I'd like to see us talking more about that as a package, a long-term treatment pathway, which is what I think will cause the most people to be able to stand on their own 2 feet. And I think we're all kind of wanting to go that direction, and so try not to see the people who are opposed to drug consumption sites as not being for the bigger picture of seeing people whole and healthy with compassion and love, as you were saying. And I just wanted to acknowledge my niece, who would have been 32 years old today. Thank you.
Thank you. Appreciate that.
Thanks, Delaire.
Last word here.
My name is Caitlin, and I'm with Hope Crew Outreach. So my mom abused prescription pills, and then she eventually got on Suboxone, and she abused that too. And she would say, till she was blue in the face, you can't abuse Suboxone. And then when I started volunteering with Hope Crew, a lot of the addicts would say, oh yeah, that messed me up way more than heroin ever did. So what are your thoughts on something that is supposed to help, but it is also hurting? I mean, depending on the person.
Well, there are 3 FDA-approved medications for opioid use disorder. So in that instance, and I'm not a medical provider, that would be something where we would understand what it means by the person is misusing their Suboxone. Does it mean they're on too high a dose? Does it mean they're combining it with anti-anxiety medications? Does it mean they're trying to take it some way other than orally? That can mean a lot of different things. And it also might be that that medication creates euphoria in that person at the dose they're taking, and they should either be on a lower dose or a different medication. So it's not a cure-all. It's not magic. What I do as a researcher is not say that this is the perfect answer for everything, but I do try to say that the preponderance of evidence is that for most people, this is a good intervention and they might want to try it. So when we do an opioid use disorder treatment decision-making intervention and we're talking with folks, it's not an intervention, it's actually an educational session. We're saying, here are these options, and you have other options as well. You know, your first option is to do nothing. Some people like to call that watchful waiting. I call it a fancy way of do nothing. But you can do that and see what happens and watch your cravings and see what the consequences are. You can get social support. And be clear that social support might be around addiction or it might be around chronic pain or mental health. Those may be really important drivers in a person's life. And they could get professional counseling. And then they may also consider medications. So it isn't that the medication is a magic fix-all by itself, but I also want to be clear that those other supports don't have a great evidence base. I'm a social worker. I love counseling and I love talking to people, but not dead people. And so I know those medications are the thing that are most likely to keep people alive. So I want to make sure that's being offered to people. But then also understand what are other services that we can offer. The challenge has been, as I came out in my training 23 years ago at a methadone clinic, that if you didn't do all these other things, like go to individual and group counseling, or you continue to use drugs, you'd get kicked out. That has changed. We now recognize that the medications are on average what keep most people alive. So the point is that's not the magic fix for everybody, that people can misuse these substances just like they can misuse just about everything, but that they really need to get good comprehensive care and understand that there are a range of different options.
Thank you very much. All right. Rachel. Oh, did you want to say something?
One more thing. There just isn't a one-size-fits-all intervention. And so what works for me might kill you, you know, and so it's really important that we understand that people really need an individualized care plan.
And we have to allow people to come back and say, I'm struggling, I'm not doing well, and that not that they're going to get kicked out or get in trouble for that, but that you're going to continue to work with people.
I just want to say thank you to everybody that you know, this, boy, talk about emotional and but informative and important, I think, too. And I also want to thank Mohai for giving the opportunity for us to do these community conversations because they are critical. I think it's an opportunity for people to actually speak out and have a place where they can engage on these very important issues. Give a hand to our panel, please. Yeah. Give me a hand. Why don't you do that too? Yeah. Thank you. All right. Well, thank you very much, and thank you to Mohai, King County TV, and our panel, and a lot of work to do. But thank you very much for what you're doing, and thank you all for sharing your stories this evening. Good night. Thank you for being here.